Hello everyone, welcome back. Our today's topic is Crohn's disease. There is a very famous mnemonic related to Crohn's disease. A fat granny and an old crone skipping down a cobblestone road away from the wreck. Here, fat represents creeping fat. Granny represents granulomatous infiltrates. And Crohn represents literally the Crohn's disease. Skipping representing skip lesions that are seen in Crohn's disease. These are the patchy lesions all around the colon. Cobblestone, as we go for endoscopy, we find cobblestones in the result, and these cobblestones are clear diagnostic mark for the Crohn's disease. There is rectal sparing, as usually rectum is not involved in this disease. There is another thing that is related to this image right here. The guy who is skipping, usually for skipping we use one leg, and there is the cell that is T helper 1 mediated cell that is involved in this morphology of Crohn's disease, in the morphology of Crohn's disease. So some people use this image to remember that. Here you can see cobblestones. That's how cobblestones, very similar to cobblestones. There is endoscopic view of the colon. Inside the colon, what's going on? These cobblestone appearance is actually an inflammation, and there are fatty. You will see these creeping fats around the colon. There are cobblestones here. Due to transmural inflammation of colon wall, there is narrowing of the colon lumen. And what is the most common location and presentation of this disease? It is terminal ileum and colon, as we described before. Therefore, patients usually present with right quadrant pain and diarrhea that may or may not be bloody. Rectum is least common location where this disease is usually found. Therefore, we call rectal sparing here. Here you can see linear ulcers and fissures in Crohn's disease as compared to normal. You can see that there is narrowing down of the canal due to transmural inflammation of the walls. There is fat wrapping around the colon, and there are fissures which are knife-like. There are linear ulcers which can eventually complicate into fistulas. Due to full thickness, they can lead to formation of canal or opening, which are known as fistulas outside the GI tract. And you can notice creeping fat here. As I described before, there are skip lesions in Crohn's disease. There is rectal sparing. There is cobblestoning. Another important feature is the string sign on barium solo X-ray. Due to ball wall thickening, as you can notice, there is the size of the canal is actually narrowing down. Due to that, after barium solo in an X-ray, you will hardly notice that that canal. So you will find that string-like structure of the canal, and that's what is represented in this X-ray. So it is another important diagnostic feature of the Crohn's disease. In the microscopic morphology, we notice non-caseating granulomas and lymphoid aggregates. As I mentioned before, this is T helper 1 mediated inflammation. What are the complications? As I mentioned before, there is transmural inflammation of the bowel wall, which may result in formation of fistula, which can cause UTI and pneumaturia. What is pneumaturia? Pneumaturia is nothing but air bubbles in the urine. Phlegmon as well as abscesses these are another complication of this. Obviously, you can imagine what's going on when there is fistula. There are quite a lot of chances of abscess in that area. There could be fibrotic strictures causing obstruction in the GI tract. There is malabsorption, obviously, because colon is involved, and the intestine, part of the small intestine ileum might be involved. There is malnutrition, and there are nutritional deficiency due to malabsorption. There is quite possibility due to malabsorption that there is formation of calcium oxalate kidney stones due to calcium deposition. Okay, another thing is colorectal cancer, in which Crohn's disease can be complicated as there is increased risk of pancolitis, that whole colon can get inflamed. Extraintestinal manifestations, they share wide area. Aside from constitutional symptoms like low-grade fever, fatigue, malabsorption, and weight loss, there are extraintestinal manifestations like in which there is joint involvement, like arthritis, like joint stiffness, like ankylosing spondylitis. Another important thing is rash formation. You may notice pyoderma gangrenosum and erythema nodosum, to the extent that sometimes we associate Crohn's disease with erythema nodosum and uveitis too. So if there are patients with erythema nodosum, uveitis, and diarrhea, nausea, and there is an option of Crohn's disease, then make sure that you go through diagnostic tests for Crohn's disease. Okay, then as I mentioned before, kidney stones are quite possibility due to malabsorption. There is a chance of calcium oxalate gallstones. You may found positive ASCA, which is anti-Saccharomyces cerevisiae antibodies. The treatment is fairly simple, but before touching treatment, I would also like to mention about smoking. Smoking is a very common risk factor for the Crohn's disease. If someone who is a smoker and have a history of family history of Crohn's disease, then there are chances of development of Crohn's disease in that patient a lot. The treatment is corticosteroids. The treatment is very much similar to any autoimmune disease. So it's same corticosteroids, azathioprine, antibiotics like ciprofloxacin and metronidazole, and infliximab and adalimumab. These are monoclonal antibodies. So here are the references for today's presentation. It covers pathoma as well as first aid, as well as it includes a lot of pictures from these resources and images from these resources. I'll make sure to add these in the description, so if anyone wants to look at that. It takes a lot of time in compiling data from all major resources like first aid and patho and my UWorld notes. So please make sure to subscribe and like to my channel, and have a nice day.